Okay, good afternoon, everyone. Today we are going to start with a series on FIS clinical psychopathology, and the aim of this series is to review the chapters of this book. And there are total 10 chapters in this book, starting from the classification of the psychiatric disorder and lasting with the personality disorder. So today we are going to review about classification of the psychiatric disorder. So, classification of psychiatric disorder or any definite classification of disease must be based on its etiology. But many of the mental illness we are not very sure about its etiology. So, we develop a pragmatic or a parallel approach for the classification of disease so that we can help in the care of the patient and to communicate with the other professional and to carry out our high quality research purpose. So in this regard, the next term is what is syndrome and what is disease. So syndrome is basically a constellation of the symptoms that are unique as a group. It may contains some symptoms which are present in other syndrome also, but it is the particular combination of the symptoms that make a syndrome very specific. Many syndrome has one specific and striking symptom. For example, Korsakoff syndrome, which illustrate its progression from symptom to syndrome to disease. Initially, confabulation and impressibility, which is found among the alcoholics, were recognized by Korsakoff as significant symptoms. Later, the presence of disorientation for the time and place, euphoria, difficulty in registration, confabulation, and time tracking like thinking were identified as a key feature of this syndrome. Finally, the discovery that in alcoholic amnestic syndrome there was severe damage to the mammillary bodies confirm that Korsakoff psychosis is true disease with a neuropathological basis. Sometimes the symptoms of the syndrome seem to have a meaningful coherence. For example, in mania the patient has many symptoms which can be explained with the help of elevated mood symptom. In this regard, the symptoms can be primary symptom or it can be secondary symptom. Primary symptoms are used to describe symptoms that cannot be derived from any other psychological event. However, secondary symptoms are those psychological elaboration or reaction to the primary symptom. So, how the classification system evolve over the time. The first major classification of mental disorder is based on whether the mental illness is organic or functional. It is based on the distinction between disorder arising from the disease of the brain, which is called as the organic mental illness, and those which and those which with no such obvious basis, which are known as the functional mental illness. As the knowledge of the neurobiological process associated with the psychiatric disorder has increased and their original meaning has been lost. Schizophrenia and manic depression are typical example of functional disorder, which has increasing evidence of role of genetics and neuropathological abnormality, shows that there is at least some organic basis for this disorder. The category of based on this thing, the category of organic mental disorder and syndrome and disorder was renamed as delirium, dementia, and amnestic, another cognitive disorder in DSM-4, as abnormal brain functioning is not confined to the dementia and delirium only. And so, organic syndrome is further classified into acute, subacute, and chronic. Acute organic syndrome, the most common feature of this acute organic syndrome is the alteration of the consciousness, and this alteration of consciousness can be dreamlike, depressed, or restricted. This gives rise to four subtype of acute organic syndrome, which are delirium, acute, subacute delirium, organic stupor or torpor, and the twilight state. Delirium. In delirium, there is a dream-like changes in the consciousness, so the patient may always be unable to distinguish between the mental images and perception, leading to the hallucination and the illusion. Usually, there is severe anxiety and agitation. Stupor and torpor. In stupor and torpor, the patient respond very purely or not at all to the stimuli, and after recovery, the patient has no recollection of the event during the event. Subacute delirium, there is general lowering of awareness and marked incoherence of psychic activity so that the patient is perplexed. Isolated hallucination, illusion, delusion may also occur and the level of awareness varies, but it is lower at the night time. It can be regarded as a transitional state between the delirium and the organic stupor. In twilight state, consciousness is restricted such that the mind is only dominated by a small group of ideas, attitude, and image. This patient may appear to be perplexed, but often their behavior is built, ordered, and they can carry out complex action. There are certain organic disorder in which consciousness is not obviously disorder, and the example are two organic hallucinations, which is caused by the alcohol abuse, in which there is hallucination, particularly the auditory hallucination, in which the consciousness is intact, unlike the delirium tremens where there is the clouding of the consciousness. Similarly, in the amnestic syndrome, and there is a clear consciousness. The chronic state include various dementia, and these dementia further classified as generalized and focal. So, among the generalized dementia, the Lewy body dementia, Alzheimer dementia, etc. The best known focal dementia is the frontal lobe dementia, and frontal lobe dementia is associated with the lack of drive, lack of foresight, inability to plan ahead, and indifference to the feelings of others. Although there is no disorientation to the patient, some patient may also demonstrate a happy-go-lucky carelessness and a humor, which is termed as the Wilch Such, whereas others patient can be rigid in their thinking and a difficulty from moving from one topic to another. The most common cause of frontal lobe dementia is the trauma, such as in road traffic accident. The presence of frontal lobe damage can be assessed by psychological tests known as the Wisconsin card sorting test or the Stroop test. The major anatomical structure which are involved in the amnestic syndrome are the thalamus, hippocampus, mammillary body, and the amygdala. Amnesia usually occurred by bilateral damage, but some cases can occur with the unilateral damage. Further, the left hemisphere appear to be more critical than the right in its genesis. So, functional syndrome. After studying the organic syndrome, let us move on to the functional syndrome or the functional disorder. Now the terms are rarely used, or earlier it referred to those syndrome in which there is no uh, readily apparent coarse brain disease, functional mental disorder, illness, further subdivided into neurosis and the psychosis. The person with the neurosis was believed to have insight into his illness, with only part of the personality involved in the disorder, and to have intact reality testing. The individual with the psychosis, by contrast, believed to have a lack in insight, had the whole of his personality distorted by the illness, and constructed a false environment out of his distorted subjective experience. And however, Jasper regarded the person, but this is not entirely true, because many cases of neurosis such as depression, the patient have changes in the personality, and also the person with OCD may have lack in the insight into the illness, and also the patient with the psychosis such as persistent 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 um, persistent delusional disorder, the personality is not affected, and also some patients of schizophrenia have insight into the illness. Again, Jasper regarded the person with the neurosis as an individual who has abnormal responses to difficulty in which some specific defenses could transform their experience. For example, in conversion dissociative disorder, the mechanism of dissociation is to transform the emotional experience into the physical symptom. This occur both in the patient and in the normal individual, but it is the degree uh, which uh, which is the determining factor. Snyder has also suggested that neurosis and personality disorder are variation of the human existence or the normal human behavior that differ from the norms quantitatively rather than the qualitative. But this doesn't explain the nature of the symptoms which are present in the patient of OCD. So the term neurotic and psychotic have changed over the time. Because of this, the DSM-4 has excluded the term neurosis completely from its nomenclature. However, ICD-10 has limited its use. There are two terms which is called as the egosyntonic and the egodystonic. Egosyntonic is something which create no distress for the person or compatible with the individual's self-concept or the ego. Egodystonic is something which causes distress and incompatible with the personal self-concept. Now, what is the personality disorder and the psychogenic disorder? In German-speaking world, it is uh, customary to separate neurosis from the personality disorder, but in German speaking countries, the neurosis were regarded as a reaction of abnormal personality to moderate or mild stress and of normal personality to severe stress. However, psychogenic reactions are reversible, prolonged psychological response to trauma, the reaction being the consequences of the causative agent on the patient personality. Thus, acute anxiety and hysteria were considered to be varieties of psychogenic reaction provoked by stress and determined by personality and cultural factor. Some stress are believed to cause psychotic reaction. Therefore, the term symptomatic and psychogenic psychosis now called as acute and transient psychotic disorder in ICD-10 and brief psychotic disorder with or without marked stress in DSM-4 and DSM-5. Snyder therefore considered neurosis, psychogenic reaction, and personality disorder were not illnesses in the sense that there was a morbid process in the nervous system, while consider the functional psychosis did represent the true illness. Modern classification system are two in number. These are DSM and ICD. DSM stand for Diagnostic and Statistical Manual, and it is mainly used in the United States of America and is prepared by the American Psychiatric Association every 4 years. And the current edition is DSM-5. ICD stand for International Classification of Diseases. It's a W Health Organization document and it covers all the medical condition. In this chapter 5, it's devoted for the mental and behavioral problem. ICD is more clinically oriented and it is not so rigid in definition. It allows clinical judgment to inform diagnosis, but this freedom make it unsuitable for research. That is why different version of ICD-10 now exist, which include clinical version and a version with the diagnostic criteria for research, and third one is a version for use in the primary care. There are comparison between the DSM-5 and DSM-11. The both of the classification system are based on the syndrome and it is not based on the etiology, psychobiology or the prognosis. The one of the there are many differences between the DSM-5 and ICD-11. One of the most important is the difference in the 5 personality trait which are similar to the DSM-5 alternative model for the MP. The major difference between the Anacostia domain in ICD-11 versus DSM-5 psychotic. There are certain interview schedule which are done in order to carry out epidemiological studies, and these are the SCID 5 and it has different version. It has now 4 version, which is the clinical version, research version, clinical trial version, personality disorder version, and there is also a screening version, and there is one for the personality disorder. Apart from this, there is a composite international diagnostic interview, and there is a schedule for clinical assessment in neuropsychiatry. This is all about the chapter 1 of the FIS clinical psychopathology. Let us meet tomorrow with another chapter.